most of the people know him very well. So without further ado, I invite Dr. Janaka Peiris to come to the podium to start this.
Good morning. I must thank KSM and this organizing committee for inviting me to give this speech. In fact, I have given this talk a few years back, but I am sure none of you remember, let alone the contents of the lecture, whether it was given you, right? Uh, Now, this movie, Vertigo, is a classic movie. In various critical surveys, this came first or second in Oxford. Citizen, there's another film, Citizen Kane, that is holding the number one position. Probably this Alfred Hitchcock classic is holding the second position. In this movie, main protagonist fears height. When he looks down from height, he gets dizziness, vertigo. So that part of the story played a critical role in the movie. It's worth watching this if you have not watched this movie earlier. Anyway, vertigo is a very common if you take primary care practice. Some of you must be doing general practice. Roughly about 20% of the your patients will be suffering from some form of imbalance, dizziness, vertigo, carcavilla. But you have to remember is that is a symptom. It's not a diagnosis. So once these patients come to you, so you have to sort out what is wrong with them. It's because what I have experienced is doctors treat this as a diagnosis. It's like fever. You can give paracetamol, but that's not the cause of fever, right? So now the problem is this terminology. Not only patients, even among healthcare professionals, there is no unanimity regarding the meaning of these words. To rectify this situation, this international vestibular classification society attempted to formalize the meaning of these words. In 2009, this called Barani Society classification. They attempted to give a definition to these terms. What is vertigo, what is dizziness, what is vestibular visual symptoms, and what are postural. These are the four categories they divided. Again, even now, although they attempted this, though people don't go by these definitions. So everybody doesn't agree with this. I change this little because that the Baronic classification is mainly ENT, vestibular system disorders. Now, general practitioners, neurologists, we get not only vestibular disorders, we get all sorts of dizziness, Karakavilla, Kalante, Jabara Kalante, and various things, right? So we have to dig into the history and find out what the exact meaning of these words when these patients come and tell these things to you. So I classified this into four categories. You need not stick to this. If you read about vertigo, various articles give various classification. But you must have some form of classification in the back of your mind. Otherwise, you can't tackle this, right? So I use this. Some people can, if you want, you can use this. Now, by dizziness, another word is lightheadedness. It's a very common form of dizziness. It's very vague and subjective. People find it difficult to describe to you. It's a sort of sensation of disturbed spatial orientation, but these patients never falls or veers when walking. It's not like a drunkard person. Now, the causes are generally medical causes: hyperventilation due to anxiety, anemia, metabolic problems, head injuries. So, this is called dizziness. Then certain people have pre-syncope. I think many of us have felt this standing in school assembly. Uh, when you about to faint, you get this blurring of vision, tinnitus, sweating, blanching of lips. That is just before fainting. So most of these occurs in standing position, vasovagal syncope you must have heard, but sometimes cardiac causes, orthostatic hypotension, autonomic dysfunction can cause pre-syncope. Then other thing is some people come and tell you they are very unsteady. That is impaired balance and gait without abnormal head sensation. These patients are unsteady, but there is no illusion of movement or rotation, feeling of rotation like in vertigo. is commonly seen in elderly people. They are sort of imbalanced, walking not steady. It's generally due to multisensory deficits. Now, with aging, your joint position sense appreciation is lost. You have osteoarthritis, your vision is impaired, your hearing is impaired, everything is impaired. So, sensory input to the brain is impaired. So, because of that, they find it difficult to maintain their balance. Sometimes certain neurological disorders can cause this, like Parkinson's disease, right? Neuropathy. Then this is the topic we are coming today. Vertigo. It's a hallucination of movement, either the environment or the person himself. It's typically rotatory, but not necessarily, and it's also often associated with certain autonomic symptoms like sweating, nausea, vomiting. So I generally keep this classification in the back of my mind, right? But today I will concentrate on vertigo. In this Barani classification, they divide vertigo into two categories: spontaneous versus triggered. Probably Dr. Atulga will describe this further. Now, one thing is positional vertigo. It's a very common thing, right? When you sit up in the bed, it's not there is no problem. As soon as you lie down in the bed, you get rotation. So that is positional. Once the head position is changed, this is different from head motion vertigo. In head motion vertigo, during the movement itself, you get vertigo, right? So then there are other categories: visual induced, sound induced, Valsalva, right? Now, as a neurologist, my main concern is when these patients are referred to me to decide whether this is central vertigo or peripheral vertigo. If it is peripheral vertigo, very simple management. I just have to write to the ETC. Then it's his business, right? But differentiating this whether it's a central or peripheral is sometimes very difficult, right? Now, peripheral means peripheral vestibular system problems. Subcircular canal, saccule, utricle, vestibular nerve problem. Central means brain stem, vestibular nuclei, cerebellum, brain stem. Right? Now, how to differentiate peripheral from central? There are a few features I have mentioned here. Peripheral vertigo is generally temporary. Now, vertigo may recur in peripheral disorders for over a period of years, but each episode lasts for a very short period. They don't last for months. So if a patient comes and says, I have been having vertigo the last 3 months continuously, it's very unlikely to be a peripheral problem. Then it has to be a central. These are not hard and fast rules, but the general rules. And generally, peripheral vertigo is of sudden onset and is made worse by head movement. It's not only BPPV, most of the peripheral vertigos get worse on head movement. Then hearing loss tinnitus you can get, but it's little unusual in central causes. So more likely to be a peripheral vestibular issue. Uh, and if a patient comes to you, laugh into a consultation room, doctor, I am having dizziness, vertigo, that is very unlikely he's having a peripheral disorder. If you have a peripheral vestibular problem, somebody will be holding that patient, right? So nicely walking about saying I'm having vertigo all the time is more likely to be a central cause. And the other thing is very clear cut. Sometimes the diagnosis, if they have other brainstem symptoms and signs, double vision, numbness in the face, dysarthria, then it's unlikely to be a peripheral problem. Then other important physical sign we look for in differentiating this peripheral from central is nystagmus. Now, if I come to it later, there's a thing called Alexander's law. Now, in peripheral vestibular disorders, nystagmus fast beating component is unidirectional. It's towards the normal ear, fast component. And it's inhibited by fixation. When you concentrate on spot, nystagmus get attenuated and usually disappears within few days. This is in contrast to central nystagmus. It changes the direction on your towards the gaze. It's called gaze evoked nystagmus, and it is not inhibited by fixation, and it lasts for a more prolonged period. So this nystagmus is useful in differentiating central causes from peripheral causes. Another important thing is if it is a vertical nystagmus, downbeat to upbeat, is never peripheral. Then this vestibulo-ocular reflex is useful in coming to a diagnosis. It was described by a physician who in fact had peripheral vestibular symptoms. I will show you this slow vestibular reflex video and head thrust. If I took it from YouTube, this is not very clear, but you may be able to see.
Slow VOR and head thrust. Check the patient has an intact VOR by moving their head slowly from side to side and asking them to maintain fixation on a target such as your nose. Try to rotate the head in a plane 30 degrees below the horizontal. This brings the horizontal canal into the plane of motion. If the patient can do this, move their head quickly to one side and then the other. Obviously, it is important to warn the patient that you will be moving their head quickly before you begin the test. A corrective saccade after the thrust indicates a decrease in VOR gain and implies a vestibular loss on the side towards which you are moving the head. This lady has a unilateral loss on the right side. This test has good specificity but lower sensitivity. Normal performance does not preclude a vestibular weakness.
Just watch again.
Watch again for the corrective saccade after rightward but not leftward head movement.
There's a corrective movement, very subtle. You have to train your eyes to pick this up, right? Right.
The head can be moved towards or away from the center.
Now this is called vestibulo-ocular. This has evolved in mammals and it's a very useful reflex. That's why when we travel, when we are driving a vehicle, we can keep our fixation on a certain target and still without moving your head we can move. This has led to even accidents now, especially male consultants. They look at passing by nice ladies without turning the head because the wife may detect it and you may meet with accidents. Now in avians, birds, they can't move the eyes. Chick develop very slight movement they can make. Because of that, their reflex is called vestibulocephalic reflex. That's why the reason now you must have seen these pigeons. They are bobbing their head up and down when they walk. So that is vestibulocephalic reflex is in action. I saw while preparing this slide nice video. Advertisement by the Benz company to demonstrate the stability of the Benz. It's a rooster with this is vestibulocephalic reflex in birds. In spite of change in the body, head remains stable. Can you see? I don't think Benz is so stable. Head remains static. So this is called vestibular. So that is in birds, right? Now I have put this in a sort of a table. Few differentiating features: central vertigo, nausea, vomiting, minimum, but in peripheral it's very prominent. And the movement of illusion, the hallucination is less prominent in central, but is very prominent in peripheral vestibular dysfunction. And with movement, head movement, peripheral symptoms get worse. And neurological symptoms and signs are rare in peripheral but common, especially brainstem symptoms and signs. And the imbalance is severe. Imbalance means unsteadiness. like a drunkard person when you have a central thing, right? But it is mild to moderate in peripheral vestibule. Then hearing loss is rare, you can get it, but it's more common in peripheral vestibular disorders. Then the oscillopsia. So when you have nystagmus, sometimes you see the image jerking this way, that way. That is severe in central causes due to nystagmus due to central causes, and is generally mild in peripheral. And as I said, the recovery takes longer in central, but in peripheral, unless you have made the matters worse by treating them with vestibular sedatives, they improve within few days or maximum few weeks. Then, as I said, this vertical, you can get torsional, multidirectional in central, but generally is horizontal in peripheral. And visual fixation makes central vertigo suppression of doesn't occur with central, but occurs with peripheral. I will come to this Alexander law, direction fixed. Right? Now this is about the Alexander's law. One minute. Now the Alexander's law means when you have nystagmus due to peripheral vestibular disorder, the fast component is towards the normal ear. So when you look towards the normal ear, you get a very prominent nystagmus. But when you look toward the other side, normal affected ear, the nystagmus get attenuated. And fixation also makes the nystagmus less. That is called Alexander's law, right? So that is also important. Just see.
Try not to blink at all. Just try not to blink. Just gonna keep you here for just a few
Sorry,
seconds.
here's a distance. This is using Frenzel goggles. Now we don't have it. When you wear these Frenzel goggles, they can't fixate, right? Then the video is you can see the eye movements on the laptop.
Okay, now look over to your left.
Now this is the effect normally.
Right there.
See the
Your eye wide
mistake was
open.
very
Wide
prominent.
open. Wide open.
Then as he comes to the center, the other side attenuate. It's still there, but very much less the amplitude.
Now come back to center.
Still there in the central position. Now he will
To
fix
left
it.
for
Now on the
3 seconds.
fixated light is on, right? You'll see
Back to center. Stay at that light.
now the pupil consider is fixing. Now the nystagmus get little attenuated, right? The fixation makes the nystagmus less. So that is all the important bedside test, right?
All right. We'll just stop.
Now combining all these, it's called hints. This is also very important now when you come across a patient with vertigo. It's called head impulse test, which I have shown earlier. Then the nystagmus, other thing is called the test of screw. If all these are there, sometimes some people say, although it's not very central, very specific. Even more sensitive than MRI in the first few hours after a stroke, right? Because sometimes strokes, even with MRI, about 10 to 20%, even DWI images may not show the infarct for 24 hours, right? So the test of screw is now when you have a central lesion, there's vertical malalignment of the eyes. One eye is up, one other eye is little down. This is also subtle, just see. Whenever this eye goes down, when the hand is covering and uncovering, it goes up. I don't know whether you can see it. This eye is little up, this eye is little down. Then another few. My time is over. Oh, can I carry on? Oh, sorry. So the duration of vertigo is sometimes useful in coming to the disease, various disease entities. Now it lasts for few seconds. Is most likely to be BPPV. There's another condition called vestibular paroxysmal. Dr. Atulga will deal with those. It lasts for minutes. More likely to be brainstem ischemic events like transient ischemic attacks. If it is minutes to hours, many years, migraine, those conditions can. So the duration of vertigo is sometimes useful in coming to a conclusion. The hours to days, labyrinthitis, vestibular neuritis. Then weeks to months, this condition called persistent postural perceptual dizziness. So it's a sort of functional disorder. Then uncompensated vestibular loss, they can last for months and years sometimes. These are the red flags. You have to be now. I'm not saying where peripheral disorders are less important, but it is central. Sometimes they are very serious causes, tumors, in strokes, many anxieties, right? Now, if these things are there, those are sort of red flags. Vertical nystagmus, acute deafness, new onset headache. If the person comes with vertigo plus any of these, you have to be very careful. Now, generally, vast majority of causes are ENT issues. I'm not going to describe those. Now, the central causes are migraine, strokes, seizures, multiple sclerosis, Kyrie malformation. Then there's an entity called cervical vertigo. Now, vestibular neuronitis is generally a viral polyviral. They get severe vertigo, vomiting. They are very ill. But you have to remember sometimes vestibular neuronitis can, the central lesions can mimic vestibular neuronitis. So if you are not very sure, best thing is to go for brain imaging using MRI, because these are the situations there where the central lesions can mimic vestibular neuronitis. Small infarct, especially in the root entry zone of the vestibular nerve, can be confused with vestibular neuritis. Then sometimes vestibular migraine may mimic vestibular neuritis. So as I said, normal head impulse test is not very sensitive, although it's very specific. So if you are in doubt, best thing is to go for imaging. Then the presentation pattern is also sometimes useful. Single acute episode, more likely to be vestibular neuritis or TI. But recurrent episodes, BPPV, migraine, manias, things like that. A few words about migraine and vertigo. Migraine sufferers often have this vertigo, dizziness, non-specific complaints. And even BPP is common among migraine sufferers, right? They have this motion sickness more than the other people, right? So migraine is 3 times common in BPP people. This is in contrast to bacillus migraine. Bacillus migraine is sort of an aura where you get brainstem symptoms and signs. Double vision, numbness, right? Then there's another condition called migraine-associated vertigo or vestibular, because there are various names of this. This is probably the most common cause of spontaneous recurrent vertigo, right? Now, the problem is how to diagnose them. If the patient gets dizziness with the migraine episode, then the diagnosis is straightforward. So, the problem is sometimes they get this disease spells without headache or in between migraine headaches. Then you are not very sure whether this is migraine associated vertigo or something else. And occasionally people get only the dizziness. Then why do you call it migraine? Because often these patients have family history of migraine. They get this photophobia during these disease spells, and they often respond to migraine prophylaxis. That's why people think it's probably migraine related entity. So I'm not going to, because my time is up. Now, again, the migraine associated vertigo, main differential that will come with Meniere's disease. Dr. Atulgam will be talking about it. Now, these few features, both can last up to 24 hours. Sensory neural hearing loss, very uncommon in migraine, common in Meniere's. Tinnitus is, even if happens, is rarely obtrusive in migraine, but in Meniere's is very troublesome. And the photophobia, phonophobia never present in Meniere's disease. Now this is not benign BPPV. Sometimes children get a benign paroxysmal vertigo. Now many believe this to be a precursor of adult migraine because these children later on develop migraine. Uh, Epilepsy can cause vertigo, but vertigo is only rarely caused. But if a patient comes with recurrent vertigo, it's very unlikely to be epileptic. But occasionally, so it can happen as an aura of an epileptic seizure. Now, if the patient develops generalized seizure following vertigo, then its diagnosis is easy. But sometimes, but it's not a common cause. Then the TIS can cause vertigo. Again, isolated recurrent vertigo due to TIS is very unusual. If at all they get other brainstem dysfunction, double vision, weakness, sensory things. If the patient comes up for years, recurrent vertigo, only vertigo, very unlikely that's due to TIS. And people believed, even still believe, now with your head movement, if you get vertigo, that is due to kinking of vertebral arteries causing vertebrobasal ischemia. That is also a very doubtful entity. It's more likely to due to BPP or head motion related dizziness, right? There is a rare condition called Bow-Hunter syndrome where in fact these vertebral arteries get kinked. But in that situation, generally they get other brainstem symptoms, double vision, numbness, right? Not isolated vertigo. CP angle tumors, multiple sclerosis. So these things can happen because I'm passing this rapidly. Now this is also important in some chronic, these are probably earlier called psychogenic dizziness. This is called persistent postural perceptual dizziness. It's a very chronic, some of these chronic disease spells are due to this. It's get worse on movement, non-spinning vertigo. They often associated with psychological comorbidity like anxiety, depression, and common among migraine sufferers, right? This is also, if you remember, this much is enough. Now, if central vertigo plus vestibular awareness is a sort of a hallucination, the brain after some time ignores this hallucinatory movement and the vertigo slowly improves, whatever the cause may be. Now, it's called habituation. Now, it is like double vision. If you get double vision after months, people, even with the squint, people will not see double because the brain tends to ignore that false image. Vertigo is also same. But when you give vestibular sedatives, what happens is if this habituation occurs in 2 weeks, if you give vestibular, it will take 6 months. So you are positively harming the patient by giving vestibular sedatives. Of course, there is a place for vestibular sedatives, especially in this labyrinthitis where they are very ill people. They are vomiting, they can't sit up. In that situation, for a short period, vestibular sedatives are recommended. I mean, prochlorperazine is called stemetil, cineracy. So you can use in that situation for a short period. In fact, I have seen stemetil being used for months and months. I can't think of any medical condition where you need to give this for more than 10 days. I can't think of any medical illness where you need to continue prochlorperazine for more than 10 days. But in clinic, those months and years, stemetil, they come like zombies to us with Parkinsonism. I don't know, I can't understand, right? Then this Prathulkam will be dealing with it. This condition like BPPV, treatment is not stemetil. He will deal with it. I'm not going to touch on that, right? Then beta histine, another thing. Now beta histine specifically designed for this disease entity called Meniere's disease. It's a specific disease. For that, it's a recommended. But I know people use it, but as a general vestibular sedative, hardly any evidence, right? So thank you. I think I took additional 5 minutes also.